Without further ado, I'd like to introduce Dr. Joan Beasley. She's a Research Associate Professor, the Director of the Center for START Services, and PI of the National Research Consortium on MHIDD. She holds a PhD in Social Policy from the Heller School at Brandeis University and a master's degree in Community Mental Health Counseling from Northeastern University. Dr. Beasley is author of the START program, first implemented in 1988, and has worked to promote the development of effective services for people with disabilities and their families for more than 35 years. START was cited as a model in the 2002 U.S. Surgeon General's report on mental health disparities for persons with intellectual and developmental disabilities, and in the 2016 START was identified as a best practice by the National Academy of Sciences Institute of Medicine. START is researched and peer-reviewed as an evidence-based practice. Welcome, Dr. Beasley.
Thank you. And thank you, everybody, for your flexibility with regard to our technical difficulties. I have to say, it's technical difficulties is the story of our lives. Life has technical difficulties, and being willing to pivot with grace is a big life lesson and a big START lesson. And so I would say we did this on purpose, but we got to do it anyway. So we're going to practice polling to make sure it works. And Beth, do I have to do anything in order to get it going?
No.
Okay.
We're going to take care of that on our end.
Okay. So you're going to tell people what to do to participate in the poll. So, okay, you'll show them. So this is a sample poll. What do you think of Joni? That's me. She's shorter than she looks. She's younger than she looks. She's smarter than she looks. I'm not going to answer that question. Please go. Okay, so what I want to say first and foremost is that the work that we do is very rewarding, and we smile a lot, and there's laughter, and there's joy in doing good work and in helping people the way we do. And our positive approaches go beyond the work that Dan described. They really are understanding what rewards us and what rewards people so that we can keep the smile. Bill Gardner was a wonderful psychologist who we worked closely with for many years. And this was the way he signed off on every single email or letter that he ever wrote: keep the smile. So who is with us today? Here's your first real poll. Get ready. Are you a new START staff person? No, this is the old, that's the old poll. Try poll number 2. There you go. Are you a new START staff person? Is START coming to your community? You have START already in place? You're interested in and may be coming? Not sure yet? Plans are in development? Would like START? Just curious? Or you're a CSS staff person?
Hello?
Okay, does everyone see the results?
Yes, so I would like to talk quickly about the distribution. So many people have START coming very soon. So you're in early development of START programs, or you're a new staff to START, or you are new staff with START already in your community. And I am very excited about the just curious people. 22% are just curious who do not currently have START in their communities. And I welcome you all. Thank you. This is a picture of our fabulous CSS team. The Center for START Services is the host of the START model, and we all work together to bring you the model across the country and to perfect our skills moving forward. And here is the list of our staff. I just want to point out that we represent people from 10 states across the United States, and we are very fortunate to have such a talented group of people from diverse backgrounds in all parts of the U.S. Our mission, as Kelly articulated so beautifully this morning, is to improve the lives of persons with IDD and behavioral health needs and their families through fidelity to the START model, with exemplary services and supports that emphasize local, person-centered, positive, multidisciplinary, cost-effective, and evidence-informed practices. As you'll see, this has meant that CSS had to expand beyond just the operation and function of the START model. As a basic premise of what we do is to build capacity, we felt that we needed to expand our reach beyond START programs to other ways to build capacity. So we do provide technical support and development to START teams, which you'll be hearing about in these orientation sessions. But we also have other professional development opportunities, including a mobile crisis responders course and a course for care coordinators, case managers, which will be coming in September. As Dan spoke of, we will also be having a psychotherapy course that will be run by Dan. And we also have the National Training Institute and the online training series, which welcomes everyone in the community to help promote that capacity. We are connected through our network with many different organizations, but especially AUCD and the ARC. And we also, on our website, we develop resource pages as the need arises. There's an excellent resource page on COVID in terms of helping people with IDD and mental health experiences. And we are developing a diversity and inclusion website with Tawara Good and Georgetown University, which will be coming soon. We send out features with information. We have social media information. And we have something called the Clinical Education Team, which is similar to the ECHO model, but has some distinct differences that we've developed. We've been operating with this method of teaching for the past 34 years. And we will be sharing more information about that in the coming sessions. Our focus on research and evaluation using a database called SIRS has expanded to a national reach with the National Research Consortium on MHIDD, which partners with universities, medical schools, people with lived experiences, providers from across the country. Our focus of research is positive effectiveness in what we try to do. We are not really focused on identifying what's wrong, but identifying what's strong in people and promoting well-being. So a big part of our research is the promotion of effective strategies toward well-being. We have a current research project through the National Research Consortium to convert the VIA Institute Character Strengths Survey to make it more accessible to people with IDD so that they can take it themselves without working with informants, and it's more accessible and understanding to them. And we're working, and this proposal was submitted to the NRC. The National Research Consortium is funding this project, and several members of the CSS team are working in collaboration with the primary investigator. That's just one example of our scope of work that we are pursuing. We also work to evaluate systems of care for people with IDD-MH. We have a method that has been used in several states around the country, using evidence-based practices to measure how people feel about mental health services, their access to them, how to promote effectiveness in their local communities and states. And we offer this both as a prequel to getting engaged with the START program, but also in its own right to help local communities to identify how to improve practices in the area of IDD-MH. So the history of the START model, and by the way, on the screen, I don't see Bob, but I have to say that one of the people that is a member of the CSS team is Bob Schultz. He and I developed START back in 1988 with a team of people in Northeast Massachusetts. And I will invite you, Bob, to say whatever you would like as I talk about this. I'll bother you a little bit, as I have over the last 35 years, to engage with me in this discussion. But we developed START in Massachusetts to really speak to the closing of state facilities. And this was back in 1988, these mental health facilities and the not so much the state schools, but really mental health facilities had people reside in them who had intellectual and developmental disabilities for many years. And the downsizing of the mental health facilities, along with an increased understanding that they were being warehoused and not getting the treatment they needed, it resulted in the state of Massachusetts seeking remedies that were more community-based. And START was developed, the acronym Systemic Therapeutic Assessment, Resources, and Treatment, which is today's acronym, was not the first back then. It was, get ready, Systemic Short-Term Assessment, Respite, and Treatment. How do you like that, Bob? I remember.
Well done.
Thank you. And it was developed in a bar while drinking. Is that not correct, Bob?
Yeah, I just can't remember which trip to which bar, but it was definitely over a cocktail or two.
So when you're developing a new project with your team, it often involves sitting together and brainstorming about what you're doing, but also what on earth you're going to call it. So that's basically how the START acronym was developed. Our mission back then, we thought, was to really support people who had been deinstitutionalized. Within the first 6 months of the program, we realized that 44% of the referrals that the original START program received were people who lived with their families. And so we realized that actually, which is now well known, that most people with IDDMH living in the community do not live in facilities, never have lived in facilities, and have relied upon their families and have lived in with their families over many years. And so we did pretty much immediately shift to understanding that families were a very important part of the community that we really needed to focus on with the START program. The people who helped us develop START, in addition to Bob and me and several others, were our founding medical director, Dr. Robert Sobner, our founding clinical director, Dr. Ann Hurley. She wasn't our clinical director, she was our evaluation psychologist. She used to help with evaluations. Bill Gardner, who was a very important member of our larger national community, and Herb Lovett, who influenced Bob and me, I think, at the very core of really understanding the detriment of reputations and how the people we were working with came to us really. So it would be like if you were introduced to someone new based on all the things you did wrong on steroids. So anything you did wrong, anytime, like, I'd like to introduce you to Joni Beasley. She has never consistently been able to remain on Weight Watchers, which is why she is always struggling with her weight loss. It's not really a very good way to frame an interaction. Yet every time somebody has the courage to seek help in the IDDMH world, it is not their love of learning, their creativity, their sense of humor that is really first and foremost, but rather what is wrong with them that is presented. While I understand that when you're referring someone for clinical services, you certainly need to have a very clear understanding of what the problems are that arise to bring you to the table, no one should ever believe that referring somebody based on what's wrong with them or what they did wrong or how they failed or how we failed them is a good way to have a full picture of that person, and that exploring all avenues of that person and their humanity is key to helping understand what happened, what the person can do, how to build their resilience and move forward. So There are two stories that I would like to briefly share. One is of Donald. Donald lived in a state hospital. It was like 50% of the time, like 6 months out of every year, right, Bob? He was admitted and discharged. I think that's right.
Yep, that's consistent. Yep.
And he had a bit of a drinking problem, which we really didn't understand. He was diagnosed with schizophrenia. He had mild ID, and he was very, very aggressive at times, kind of frightening in his aggression. He didn't really say much when he became aggressive. It was very unpredictable, which was very scary. Donald was never really spoken of in a positive way prior to us working with him. And we worked with him in a residential program, and this was before START. So Donald influenced the development of our practices. And basically through our work with Herb Lovett, we began to see that his reputation was really not as important as who he really was beyond that reputation. And when, one of the things we talk about is coping skills, and people need to cope, and Donald couldn't cope. Well, the big question was what on earth was he coping with? What coping with what? Not just coping, but coping with what? It turned out through a series of observations, discussions, and evaluations that Donald had temporal lobe epilepsy. And as a result, he would have what is called partial complex seizures, which are seizures you couldn't really see. And during these times, part of his post-ictal activity was to become very aggressive and also very clouded. So he didn't know what was going on. He kind of looked like his mind was playing tricks on him. And that would lead to all kinds of interventions. It would also lead to an increase of medication, which increased his seizures, lowered his seizure threshold. Once we discovered what was going on with Donald, we were able to engage him in proper treatment, but even more importantly, in a positive way of viewing him. And then he started to see himself in a different way. Would you like to add anything to that, Bob?
Yeah, I'd like to add a couple of things. I guess one of the things I took away from my involvement with Herb Lovett was just that any of the people that he worked with, he never worked with them as if he was the doctor to client. It was very collateral. They would go out, they would go to parties together. It was a real supportive relationship. And one thing that Dr. Lovett always said that stuck with me is that you need to remember is whose life this is anyway. And one of the things I always took away from Donald was, and again, my working with Donald occurred after the seizure disorder was identified. So in terms of the aggression, when I started, I didn't see a lot of that with him. But what I did know of Donald was that he was a very kind, loving man who was dealing with a lot of stuff from his past. And one of the things that always struck me was that he lost his father in a plane crash. And, I just thought about how that must feel. And I tried to approach my work with Donald from a point of being his friend and understanding his humanity, and helping him when he needed it and being there for him. And, Donald lived in a house, it was all women in the house. The fact that I was there, he really enjoyed it. And we enjoyed our time together. So yeah.
So Bob was a direct support person at the time, and I was the I supervised the director of the program as the clinical director of this agency. And while we did use rigorous practices, Dr. Sovner really ensured that we had very rigorous clinical standards. And as Herb did as well, we also made sure that we knew Donald as a person. And as we appreciated him as a person, he appreciated himself as a person. And I think one of the things that we really forget is that in some ways we have to do positive modeling because people have very low self-esteem because of their life history that undermines their ability to use their strengths and build that resilience that we've been speaking of. So very quickly, I just want to talk about Maureen, and then I will move on. Maureen was a little bit different. She, and again, all of these people kind of influenced how we developed START and how I thought and wrote about the model, and how I collaborated with our first team. Maureen was diagnosed with severe to profound, moderate to severe ID. We don't really know what her level of intellectual disability was. It could have been a little higher, but she was a woman of few words. She didn't really speak very much verbally. She had grown up in the institutional system. She had started out living as a child in the child mental health hospital and then was transferred to Fernald State School across the road when she turned to adulthood. She talked a lot about babies and having babies. It was considered her delusional material, and she was also diagnosed with schizophrenia. She became very upset during transitions, and she would scream for probably 30 minutes a day. It was usually while we were having staff meeting. Right, Bob? So we were very aware of it, and we tried to console her, and she was pretty much inconsolable. It was a very loud and shrill scream, very disruptive, disturbing, and really represented that she was quite disturbed. She did things like hoard her underwear in her purse, which was explained by the fact that she lived in an institution her whole life and people hoarded their belongings. Well, through a record review, we discovered that Maureen had been raped as a young adult while in the facility, and in fact did have a child that was taken from her. Back then, this was 1985, nobody talked about trauma in people with IDD. Nobody just talked about PTSD in our population, but clearly reflecting back, what Maureen suffered from was severe trauma and PTSD. Through our positive engagement with her, she was probably one of the most beloved people that I've ever worked with. She had a great sense of humor. She was actually a lot of fun. It took a long time. And I would say we created a trauma-informed care program without knowing what that meant. We made her feel safe. And also, once we learned about her history, it kind of cleared a lot of things up. Maureen would end up tied up in restraints in the emergency room a lot because of her dysregulation. I remember sitting by her side while she was tied up, telling her that I didn't know how we were going to get out of this mess, but I wasn't going to leave her side until we did. And those kinds of things really built over time. Those people that you serve that may have stories that begin in this kind of detriment and despair can actually encourage you to think differently about the work and inspire you to do more, do better, to think differently, and to share their stories as part of your mission. And that is really what we did when we developed START several years later in 1988. From the beginning of START, we have been data-driven, strength-based, with rigorous clinical standards. If any of you know the people on this list, we were very, very fortunate to be founded by national leaders in the field. Back then, I was sort of the kid. I have since matured, as we can all see. And the first replication of the model was in Tennessee. I know there's a lot of Tennesseans with us today. 10 START taught us a lot of lessons. And one of them was you need to write things down. You need to really think strategically. And they're definitely part of our mission and our model going forward. So we have a crisis intervention model, which has several guiding principles. They include, so one time many years ago, I invited someone who was very famous to come and present to our team to teach us. And she said, I'm person-centered and you're clinical, because we worked with Robert, and the two do not mix. As a mental health clinician, if you are not person-centered and clinical at the same time, you are not true to the work. They are not separate. You can have a biopsychosocial approach to assessment and treatment and be quite rigorous in your understanding of the mental health and health needs of your client while being trauma informed, while being strength based, and definitely, most importantly, remembering that the culture and language and access to care and access to you has to be first and foremost, that you have to be competent in that approach. And finally, I would say to remember that we are an apprenticeship, that when you're doing this work, there is no, it's really an art. It is not a science to do good clinical practice. It does include some scientific methodology, like art does have some structural things that you need to learn to practice art, to work on a to work in pottery on a potter's wheel. You have to learn how to turn it on. You have to learn about the speed of the wheel. But that doesn't make the beautiful pottery that results. It really is a combination of understanding the technical aspects of what you do, but also remember that there's a creative side to it. There's a human side to human services that can't be forgotten. So we really believe that START is a practice that relies upon coaching, that relies upon contact with each other, and relies upon modeling the way. So we are a fidelity-based model, which means we have certain expectations in order to call yourself a START program, to maintain the integrity of the program, and to be able to effectively measure and promote our desired outcomes. But it is not a model that doesn't have flexibility and cannot be applied in different ways in different locations. So our START model practices include cross-systems crisis prevention and response, which you'll be hearing more about on Friday, comprehensive multimodal assessments, an integrated health approach. We've been using multiple modalities our entire history, 34 years. We know that if you don't feel well, you're not going to present yourself well. I can poll everybody to see how many people with constipation have a good day, but I will leave that to you to think amongst yourselves. The practices include, as I said earlier, outreach, coaching, education and training, and collective learning, linking the system, so that one of the things that we embrace is to remove those silos that we all live in and work in, because people have, when you've met a person with autism, you've met a person with autism. We should not expect that every person we meet who has a label of a particular disability or level of ability is just like the next person. So the more we can open up the capacity to be able to all understand each other, the better people will be served, and the better people will need fewer services. So not every problem is solved with a service. Most problems are created by the lack of opportunity in the person's life. And so you can't really ignore lack of opportunity when you're trying to promote quality services and capacity. We rely on a well-trained workforce. We have very rigorous standards of training and measuring whether or not people have learned from those trainings. And of course, we're evidence-based through our research and evaluation. So I'm going to continue our discussion about START and about the START program, and share with you who ordinarily gets referred to START and why. This is a common question for new programs and for people and areas that are interested in developing programs. So first of all, START is a lifespan program. It runs from ages 6 through adult. We do not work with preschool or early intervention children, but the programs do serve children who are school-aged and over. And we find that it's really helpful, especially because transitional youth tend to have issues that fall we used to call it falling between the cracks or some nonsense like that. But the truth is this: there are many systems failures in supporting individuals and families once children and young adults are transitioning out of the school system into the adult system. And the benefit of beginning earlier helps us to identify how to best support that child into adulthood and also help them transition into adulthood and adult services. We are a program for people diagnosed with intellectual and developmental disabilities, and they often use mental health services or receive mental health services. So a lot of the people referred, you might think about referring, are children and adults who are being treated with medication to control their behavior or their presentation without a mental health diagnosis, which can occur. Primary care physicians, pediatricians might prescribe for behavioral control. Behavioral control. I wish you could see my little quotes. Or people who are receiving mental health services. And this includes medication, hospitalization, crisis services, and outpatient services. START is really not designed for everyone who uses mental health services who has IDD, but people who don't seem to be benefiting from those services, people who are not doing well or have a worrisome presentation with regard to their overall well-being. So they've had lots of placements, or they're worried about losing their home. They have lots of people and plans to manage their behavior. And they're jobless, they're sad. We have kids who are told they can't participate in school, in the school day, and have to be tutored at home. This is not COVID related. So there's lots of variation as to who gets referred to START. Your local entity decides, in terms of the IDD eligibility, who is eligible. So OPWDD in New York might be slightly different from DDS or Tennessee or Texas or other places that we work. And those are usually worked out through your local entities. Other people who could be referred are just about anybody that you're worried about. If a family member is worried, difficulty with challenges in their person's presentation, lots of problems with very few solutions. And really, I think the most important thing to remember is that what we're trying to do is give people help so that they have hope for the future. And I'll tell you, Dan's phrase is exactly what we're working on. We are not working on modification of the person's behavior. We're working on modifications about beliefs about that person and their beliefs about themselves. And so if you have beliefs that this person needs restrictive services, they need to be segregated, siloed, medicated, then they're a good referral for START. So what I'd like to say is what we're going to do now is we are going to go into breakout sessions. Are we not, Beth?
We sure are.
And we're going to do it this time, kids. Those of you who have stuck with us through thick and thin. So we have 10 minutes for this breakout session. And given this list, which I will keep up on the board, which you won't be able to see anyway, will they, Beth? No, they will not.
No, they will not.
My two questions are, do you know people who could benefit from START in your local communities? And what elements of the model are most important to you? Is it the diagnosis and assessment part? Is it the strength-based approaches? Is it the crisis prevention and intervention part? Is it the educational part, the coaching, the things that I've described earlier? So I want to give you 10 minutes to really think about that in your breakout sessions, and we will begin now. Oh, please assign a person to represent your group, and Beth will be calling out your, do people have group numbers, Beth?
They will note their room number, and I will call on a few randomly when we come back in.
Randomly select groups, so you don't know whether you're going to be called, so please do your homework.
You should see a prompt that says join, click that, and it'll bring you into your breakout room.
Thank you.
See you in 10.
So START is a program within a network. And it's important to remember that the START program in your community cannot work by itself. Actually, there's one great partner that I just want to shout out to, and that is all of you service coordinators and case managers. START really does enhance the capacity of case managers and service coordinators and case managers enhance the capacity of START. It's a true partnership in identifying who has needs and how to work with systems to promote effective care and service delivery. So that, in that sense, on the very small, on the ground level, those partners are very important. On a wider scope, their network partners include members of your advisory board. So each program has a local community of leaders and advisors to reflect on how they're doing, to talk about future planning, and to really modify services and supports based on the feedback and with the feedback of the advisors. Advisory boards should include people with lived experiences and families, as well as professional partners. And it's really important to have diverse professional partners representing the education system, the mental health system, as well as the IDD system, and not to sort of silo your network based on your comfort zone, but really go beyond the comfort zone to expand that network. And the third element is linkages. The START programs develop linkage agreements between START programs, and other services, and around, and also to engage with other resources in the community that might be helpful to people enrolled in the START program. What's important about linkages is that it really enhances your capacity, and I'll talk about that in a few minutes. It's a fidelity-based model, but it has to fit within the local entity. We're not a cookie cutter approach. So Tennessee START is going to look different from California START, which is going to look different from the Oklahoma services that are being developed, which is going to look different. Shout out to my Connecticut friends, which is going to look different from some of the other new programs that are now coming on board, Denver, Colorado, for example. So while it's a fidelity-based model and we have defined expectations, the way it's embedded is very different. And of course, we have California, where every regional center has its own culture and identity. And so START, even California START, has to be different in different locations of California. The same is true in New York, where START is 80% statewide. So we also require a real thought, and we push this from the minute we engage with the system and the people we support around reframing from bad reputations to really thinking about how to look at the strengths in everyone, including the state, the people, families, providers, and educators. When you're stressed, it's very easy to sort of attribute the problems that lie in one element or another in your community. It's probably unlikely that any one element is really responsible for the problems that you face. And it really undermines the ability to collaborate when you really focus on bad reputations or repudiation of your partners. So we really try to engage in positive systems work. We also rely on expertise, which is developed over time and with effort. It's really a lifelong journey. I have to say that what I thought was true 10 years ago in my clinical work, I don't agree 100% with all the things that I learned then, and my practice has changed now. And if you go further back in time, in all of our training, we can't get stuck with what we thought was true. And, Maya Angelou said, do the best you can until you know better. And when you know better, do better. That is a constant journey that we're on. Really, there isn't a lot of good training in graduate school and professional training in IDDMH. And even if there were, they would have to continue to question and learn from their experiences. So START programs are required to develop expertise within the program. We see you as leaders in the field. We're here to help you at the Center for START Services, and then sort of launch your expertise, continue to be part of our network. But really, the go-to people in your community should be the resources that develop within your community, not from outside of your community. We modify practices to include people with lived experiences because they have something to say. So one of the old misnomers was people with IDD cannot participate in a clinical interview to better understand their mental health needs. We now believe, and we now try to practice, that what was wrong was not what was wrong with the individual. What was wrong was the way we were approaching evaluating the individual so that we could engage them in a conversation, even if that conversation is nonverbal. There's a way to engage someone so that they can participate actively in their own care. It is our obligation to dedicate our work to making sure that that happens. And the listening has to include families who also have something to say. The perspective of families is the perspective of families. It is not the perspective of the individual. The individual has their own perspective, and both have value. We rely on data collection and evaluation, and we really have to be rigorous. We have objective measures, and we continuously evaluate what we're doing and who we're doing it for. And the whole goal is to build capacity. So I'm going to use this capacity model. It's a public health model, and I'm going to demonstrate that through the COVID crisis that we are now in. Right now, we're in the tertiary part of COVID. We're facing the odds. We're diagnosing and treating people. Primarily, our mission is to deal with COVID to the best of our ability, but we really don't have a great deal of capacity to address COVID. And so we're in crisis mode. And so we're facing the odds of COVID and doing the best that we can. We have some strategies to beat the odds: social distancing, wearing masks, working from home, virtual supports. And that helps us to prevent the widespread illness that can occur with COVID. But as you can see, those secondary interventions are not really interventions that are owned by the wider community. And you can see that some places believe it, others don't believe it, some buy into it, some practice it, some don't think they practice it, and that results in tertiary intervention being the most relied upon intervention. What we are trying to do is develop vaccines and better treatment, and those would be considered secondary interventions, especially treatment. So beating the odds of ending up on a respirator, for example, through these treatment interventions. But what we're really all looking for is primary intervention, changing the odds. And those primary interventions include inoculation from COVID so that people can get a vaccine, and we can, and good treatment so that it becomes just a very bad cold instead of a deadly illness. And that's a primary intervention. And that changes the odds and builds the capacity for all of us to live better lives. Well, with START, what we're trying to do is move from reactionary tertiary intervention, where people end up in emergency rooms and facilities, where they end up in restrictive services, or where they rely upon secondary interventions, which are siloed subspecialties, to primary intervention, where we change the odds of needing those services through building capacity, both on an individual level, a family level, a provider level, and a clinician level, that we all have a better understanding. Teachers, primary care physicians, pediatricians, mental health clinicians, DD staff, all have a better understanding of how to better support an individual and to promote inclusion and acceptance in ordinary life, so that people with IDD who have mental health needs can go to school and be educated, can get jobs, have lives. Because really the biggest primary intervention that changes the odds is allowing people to live a rewarding and humane life. So our tertiary care model, which is adapted from a public health model, really is embedded in all of our practices at START. And as Dan said, we have a choice about how we view something, and we can change how we as a group think and feel about what we see. And we can cultivate sustainable positive feelings about ourselves and in our work and in the network around us, which can create and inspire that in others through this approach. Karen Weidley, Alice Benson, and I, and Dave O'Neill yesterday participated in a meeting for very early referral with one of the new programs on the West Coast that is now in development. And in the meeting itself, we went through this process of asking questions and having active dialogue. And we left the meeting with positive feelings about, especially a shout out to Ted, if he's out there, a shout out to this person who was talking about this individual that he really cared about. And really those positive feelings about how we can make a difference and be inspired to move forward despite the challenges that we face in the new referrals that we receive at START. Usually when you're first starting a program, the people who are first referred are the people in the most desperate need. And really their stories can be quite tragic and maybe hard to feel positive about. But we were able to, through thinking about what the person has to offer, what we have to offer that person, how we can think differently about this person's life, how we can engage this person, can turn a corner and change from trying to modify this person's behavior to belief modification. I really love that. That quote from Dan will be used by me going forward. Behavior modification to belief modification. If you modify beliefs, then your behaviors moving forward will be quite different from just modifying behavior alone. So this is what we're trying to do through positive thinking. There are 3 A's to effective services that I studied back in 1997, which really influenced the START model. They're access, appropriateness, and accountability. And of course, what we're all trying to do is give people effective services. So access means that it has to match the person's, that it has to be available to the person. So if someone needs mental health care, it has to actually be available to them and has to be timely. Appropriateness means it has to match their true needs and provide tools have to be provided to make things appropriate. So mental health providers who do not have any training in how to understand how to approach somebody with IDD, you may have access to mental health outpatient care, but it may not be appropriate and therefore it becomes ineffective because the clinicians don't know how to provide that care. And so one of our jobs is to make it effective by working with those clinicians to improve their skills and abilities. And accountability is a really important part of effectiveness. We have to be responsive to needs of people and systems and networks. We have to engage. We have to be flexible and creative. And we actually can't be overpriced. So, knowing that resources are limited, knowing that everybody is challenged, means that everything you do should be the best that you can do, and that you should be accountable for making sure those outcomes are as good as you had hoped they were. And if they're not, to change your practice to make it better. So I want to talk a little bit about PERMA and how we use PERMA in START practices. So on the left are Seligman's definition, which Dan spoke of earlier today. And the strategies that we employ to promote PERMA, which is a measure of well-being, are on the right. And I'm going to just talk about positive emotions because that's what Dan focused on today, but I offer this entire chart to you. Tomorrow's session will focus a lot more on positive psychology. So this is just a bit of a sample. So as you can see, START strategies embed the concept of well-being, the promotion of well-being through PERMA in all of our practices. So Seligman's definition of positive emotions include enthusiasm, hope, joy, love, gratitude, amusement, and pride. Those are all positive emotions that give us the ability to have resilience and to enjoy life. And what START practices include is strength spotting, reframing so that people, instead of thinking about what's wrong, thinking about what's strong, acknowledging people, opportunities to smile and laugh, attention to beauty and excellence, nutrition and exercise. The promotion of health is equivocal to the promotion of positive emotions. Promoting a good sense of self and attention to primary health care. When you need primary health issues addressed, it really helps you to have positive emotions. You feel better when you have them addressed. A big focus for us is cultural and linguistic competency. We all have multiple cultural identities, including the system in which we reside has its own cultural identity. But one of the things that people with disabilities are often robbed of is their cultural identity. Somehow having a disability overshadows their roots. And one of the things that we realize in all the work that we do is that it does matter what your identity is. And cultural and linguistic competency is key to really making sure that the strength through cultural identity is promoted and supported through the work that we do. Language and the words we use matter. They matter. And so we're constantly and continuously attending to that and modifying and addressing that. And it's an endless mission. I make mistakes every day and try a lot to make sure that the mistakes that I make in the future are not the same as I made today, and hope that I am developing these skills over time. Different conditions draw on these layers of experiencing different ways due to what we do. And one of the biggest issues that we have to address is bias. So I'll give you an example in mental health where there's a lot of bias, and that is the diagnosis of borderline personality disorder. Back in the 80s, when I was a mental health practitioner, that was a very derogatory diagnosis. It was a legitimate diagnosis in the DSM, but also had so much stigma associated with it that people were literally called borderlines. And, you would say, oh, they suck the life out of you, and nobody can work with a borderline. There was all of this stigma and cultural incompetency associated with it, that it really did not allow people to see people with post-traumatic stress disorder, borderline personality disorder, for who they were. And what ends up happening when you have these kinds of events is you decide that there's only one treatment approach. So everybody knows there's only one treatment approach to PTSD, and that's DBT. I hope you're all laughing, because that's not true. There's only one treatment approach to having challenging behavior, and that's applied behavioral analysis. That also is not true. There's only one treatment approach to depression, and that's medication. A third thing that's untrue. Now you might be saying to yourself, how does this fit into cultural and linguistic competency? Well, it actually does, because many of the disabilities and illnesses that people suffer from or diagnosed with they overshadow the ability to see the person and see what their needs are, and to explore the best practices to help them and to understand what they need to develop the best person that they can be. And so these are keys to understand for START programs to help lead the way to positive change. We see cultural identity, being African American, being Asian, being Hispanic, as one issue, but also having a mental illness, having autism, having a developmental intellectual disability as also being part of the picture where stigma, isolation, and segregation can reside. And all of these cultural issues have structural limitations in our society which do not allow people to flourish, And it's our job to really overcome these barriers and to include all of the person's identifiers and to overcome our biases by really looking at the person as a whole. So in order to be comprehensive in our assessment, we use a biopsychosocial model to both diagnose illness, but also to promote wellness and well-being. And biopsychosocial is defined by biomedical, psychological, and social contexts to which we all reside. We also measure what we do. We have the SIRS data reporting system because we believe that in order to really know whether or not we're doing works and whether or not we're dealing with people the way they should be dealt with, and whether or not we're providing the right information to stakeholders requires a data-driven system. And so all of the START programs throughout the country report to SIRS, and we analyze the data. And you'll be hearing more about that as part of the orientation going forward. We're an evidence-informed practice, which we, and that means that it incorporates the best available research on an ongoing evaluation and assessment to inform our interventions. So we use the information, it's sort of a circle where we identify the data needs, we collect the data, when an issue arises, we ask questions through the data, we analyze the data, we share the results, and we use the information to modify and improve our outcomes. Our data is very important to the START model to make sure that what we're doing is working to the best of our ability across the country. So we share ideas across systems and disciplines, and that best informs our practices through collective intelligence. So I'd like to just talk about collective intelligence for a minute. There are many opportunities for us all to sit in a room together, especially now on Zoom. There's lots of opportunities for meetings and discussion and dialogue. And those opportunities can sometimes engage people and sometimes not engage people, because you have to believe in collective intelligence in order to let other people talk other than yourself. And so I'm going to tell you about this study, which I thought was fantastic, that was published in the New York Times in 2016. What they did was they looked at several group interactions in a workplace. I think it was Google, actually. And they, to try to evaluate where do people perform best when they're working in groups and dialoguing. So one group they selected was just leaders, people who had expertise working together as a group. And they sort of competed with each other to show which one of them was smarter. I know nobody has ever been in a meeting like that. And then there was another group where they had people who were lower level people meeting as a group, and they also had a dialogue. And then they had a third group, which had people with mixed roles. But one of the things that they tried to ensure was that everybody had the chance to talk. One group self-initiated of experts, one group self-initiated of peers who were in the workforce who were not considered experts for their ideas, and one group where they were able to share across disciplines, but everybody had the opportunity to speak. The group that benefited the most, that learned from each other and was the most productive, was the group of people with mixed experiences. So what does that mean? They were able to share ideas, learn from each other, and listen. What we try to foster with START is a meeting, for example, where the psychiatrist, direct support professional, the person themselves, the START coordinator, the case manager, and whoever else is involved in the person's life, the teacher, all have the opportunity to speak, rather than the traditional medical model where it's a hierarchy with a person who has the most senior label or authority does all the talking and maybe asks questions of others. Promoting true dialogue is what we focus on, and engagement of everyone is a very important part of our practice. And as a result, we have seen the benefit of collective intelligence. What it does is it inspires everybody to be at their best and to also learn from each other's experiences. The thing that we have to remember as human beings is really it is not our role that shapes our lens, it's actually our humanity. And as long as you're all meeting amongst human beings, that humanity comes through and that creative process can really flow. So I urge you, the next time you have a meeting, to make sure that everybody has the opportunity to speak. Now, what I do in practice on Zoom is I call everybody to speak, because sometimes it's really awkward. People don't like to interrupt. But when you're in a meeting with me, you know I'm going to ask everybody something. The other thing I like to do is begin every session with a few words shared by every participant and close every session with reflections from every participant. Just a word or two on how they're thinking things are going. That allows that collective intelligence to flourish and really invites that kind of participation. That's a really intrinsic and a valued part of what we do at START. I'm wondering if there are any questions or comments, Beth? And if you're talking, you're muted.
No, I was not talking. Let's see. There's some comments, but I'm seeing a whole lot of questions. There was a question from someone in East LA about whether or not the referral goes through different types of insurances.
So I don't know.
Yeah.
South Central, East LA does not currently have START. South Central does. And that's all I know.
And we can connect them with.
And we can connect them. For
Yes.
the LA folks, there was discussion about reciprocity with the other regional centers to allow referrals outside of the. Is Mary Lou there?
Yes, I am.
Can you say something about that?
Well, I'm sorry, my dog decided to bark. We talked about possibly with the 7 LA regional centers developing user regional centers that could work with our START teams once they get started, and we do it through shared vendorization. They would become user regional centers. They will understand that.
Okay, and what about the insurance question?
I don't know about insurance. You would have to be, I mean, whoever's doing it would have to be paneled with the insurance company.
Right, right.
yeah.
So then you'd have to ask what, okay, but you know what? That's a really good question. And I think DDS is on in this meeting. So whoever asked that question, it's a brilliant question, because there are people who are not on Medicaid, and maybe there's a way to make sure that they get access to the service if they need it. And we'll definitely bring that up.
Thank you. And I think people are already chiming in when sharing their email addresses to connect in the chat.
Perfect. Wonderful.
Thank you. The follow-up question to that was, what is the length of involvement in the START program?
Okay, so the average length of involvement in START is about 15 months. That's on average. What we've learned from a recent analysis of when the people kind of begin to stabilize, it takes about 8 months. So people end up using a lot of START crisis services and assessment the first 8 months of engagement, and then it really stabilizes. But what happens after they're stabilized is everybody has to build capacity to support that individual without START. So it takes another 4 to 6 months for the system of support to be able to actually address the needs of the individual without involving the START team. And so once you figure out what to do, which takes several months to kind of figure that out, then you build capacity through training and coaching and outreach visits, increase capacity. You're doing this all along. And then in about 13 to 15 months, people usually are discharged. One of the things that has been very exciting is during this terrible COVID thing, we reached out to many people who had been discharged from START in the year prior to make sure that they were still stable and didn't need START. And only about 10% of the population that had been discharged after successful services required any support at all from START, even during COVID, which is a really, really positive outcome. So it doesn't mean that it works that way for everyone, but for the vast majority of the people we've supported, it's been highly successful if you allow the assessment process and the ability to really learn about what to do to go on. That person will not end up back in the hospital. I know my Connecticut friends are out there. We work together on using these methods in Connecticut. We work to deinstitutionalize people who had been in hospitals ranging from 5 to 35 years. Over a 10-year period, I worked with the state of Connecticut, and we deinstitutionalized and successfully placed about 60 individuals. The return rate to the institution was like less than 1%. So if you take the time to use these practices and really learn how to support people effectively, it's quite effective.
Couple more questions, Joni.
Yes.
Someone said, sounds like the individualized, strength-based, family-centered, needs-driven planning approach popularly called wraparound.
So wraparound is a slightly different model, although we have some similarities to wraparound. Wraparound, actually, there are hybrids of wraparound that look more like START. So what START provides, which is a little bit different, is we do a lot more outreach, a lot more training, and we're on call 24 hours a day, 7 days a week. Most wraparound teams are not. If somebody is in wraparound, they often partner with START. The other program that often partners with START in some locations are ACT teams. So while ACT is a comprehensive integrated approach for adults with mental health conditions, it isn't quite the same as what START has to offer. And so what you don't want to do is duplicate what exists. So if a child's in wraparound, then the wraparound team would get together with the START team and say, what is it that START can do to enhance wraparound? And the same thing with ACT. But the other thing that happens with wraparound is when the kids age out, they don't have anything. So some wraparound teams get involved with START about a year or two before they're transitioning into adult services so that START can get engaged at that time. But wraparound's an excellent model, as is ACT.
Thank you. Joni, one more question if you have time.
Sure.
How do you maintain the client's agency with regard to person-centered planning regarding who participates in their meetings if you pre-plan to include everyone who works with them? Are they included in the planning meetings? Are the meetings held even if the client asks that you not?
Okay, so there's two things. We do not hold person-centered planning meetings. We hold START meetings. Those meetings are not about the person, but more about our practices to support the person. And so if a person wants to be engaged in that dialogue, that's fine. If they do not, we will not talk about the person's needs in particular, but our needs around how to support this person from the position of how we all work together. So we would talk more about training needs in autism, or making sure that somebody gets a psychopharm eval. And if they get a psychopharm eval, obviously the patient, the person receiving the medication, would have to agree to that evaluation. But overall, I would say we've had very little refusal, because really the first thing we do when we get a referral is meet with the individual and say, we're here to help make their services and supports better for them. And we are here to help identify their strengths, abilities, and wishes so that they can be seen in a different light and so that they can have a better life. And most of the time, most people like that. So we've had very little refusal. But whoever asked this question makes a good point. It's certainly voluntary. In terms of getting everybody in the room, there are many things that we do in terms of systemic work that allows for people not to be initially engaged, but we continue to move forward. So, for example, if I'm working with a group where only 3 members of the system are willing to meet, and there are 2 others who have a lot of skepticism, I will reach out to those skeptics and really try to engage with them in hopes for the best. We will not make plans for anybody that doesn't include them in the room. And we will build a foundation of capacity wherever it lies. So sometimes the solution we're not an overnight sensation. So sometimes it takes a while to get people engaged, but over time, they start to see the benefits through our modeling the way to those benefits.
So, Joni, there's one more question if you'd like.
Sure.
How can individuals and families access this kind of information that we're hearing today?
Beth?
Well, to answer that question, you can visit our webpage, and we'll post the link again. We will be posting recordings of this presentation and all materials on the webpage that's associated with this event, and it should be up within the next week. And you're welcome to share it.
So I have to say, one thing that I sometimes disclose, don't always disclose. I am a trained family therapist in structural strategic family therapy through the Philadelphia Child Guidance Center, Jay Haley and Salvador Minuchin. Some of you may be familiar with them. And I had the good fortune of being an extern in a program associated with the Philadelphia Child Guidance Center. And so that's my training, is in working with families and understanding the ecology in which people reside and the importance of being respectful of that ecology and also in supporting that ecology. So that's number one. Number two, I am a family member of people with disabilities. My nephew has autism. My sister, older sister, has ID. And my mother was physically disabled. She was wheelchair bound most of her adult life. So most of her later adult life. So I am somebody who sees people with disabilities as people. It is a practice to remind ourselves that they're just like we are just like they are. Many of us who are able-bodied today have had periods of time when we weren't. My own personal story is I recently had cataract surgery that did not work, and they left a piece of the cataract in my eye. To make a long story short, I was unable to see clearly for 5 months. That loss of my sight has really, really undermined a lot of things, including my self-esteem, and frustrated me. There were members of my team that advocated for me. There were members of my team that ignored my disability. It was a very interesting experience that really reminds me of the importance of really knowing that any of us can have a vulnerability at any time, and that we must all be treated with respect and dignity. So this slide is really important to me. We talk about Maya Angelou. I talk about her a lot. This quote just really struck me to the core, because it allows us to understand that no matter where we are with regard to social justice, which I do believe that START is a model for social justice and tries to be a model for social justice. And any given day, we're doing the best we can with what we know. And our job is to know better. And then when we know better, to do better. And so all of you who are now sitting in the room with us and working together with us in this mission, this is our goal. So it doesn't really matter if we're all on the same page or if we all know the same things. What matters is doing the best you can until you know better. And then when you know better, doing better. I love the idea of challenging your perceptions, remembering that perspective and orientation really affect the way you offer help to people, and that really we're on the road to belief modification, which doesn't mean that we're not asking people. Belief modification doesn't mean that if somebody is aggressive or has a challenging presentation, that we are a culture or an environment that accepts that. It is not acceptable. But our beliefs about what people are coping with, how to understand them, and define how to help them does rely upon knowing more, knowing better, so that we can do better. So when we implement the START model, there's no excuse for not working to know better. We do provide rigorous diagnostic and treatment standard protocols. And I have to say, one of the things that we do a lot of training on is genetics and what we've learned from genetics and genetic syndromes. It used to be that going to a geneticist just created a bias, an inevitability. If you get diagnosed with a genetic syndrome, it just was sort of sad news for everyone. And people blame themselves for carrying the gene. That was sort of the biggest bias when I was growing up. The world of genetics has really changed, where treatment approaches, understanding of the way people present themselves, the way to better support people, the way to better understand people comes from that. These rigorous diagnostic and treatment standards that speak to things like genetics and really understanding people's health and mental health conditions is key to implementing our model. And to remember that the people who are being referred to START are not the failures. People do not fail, systems fail. It's okay to acknowledge that we fail as long as we learn from it and do better. The other big message is that it's not about the pill or the plan, it's about the person. So it's key to not get focused on, did he take his meds? Does he have a treatment plan? Before understanding, how do we see this person? How do they view themselves? How do we see this whole person approach, including the way they identify themselves? What is the worldview of this person? And then it becomes much easier to prescribe proper medications or to support an effective plan. The next one is, without oxygen, we cannot build hope. So I'll tell this quick story. My mother used to come and visit us every Sunday to play Scrabble at my dining room table and have lunch. And she was a very good Scrabble player. And she also was very good at taking credit for her wins. So when she won the game, she would, brag about that. When I won the game, she would brag about that and say that she taught me everything I knew. So she always won the game. And she was a wonderful, funny, talented person who happened to be non-ambulatory. And one day we were playing Scrabble, and she was unable to breathe and held her neck. And we called the ambulance, and we're very, very frightened. And when you're calling for help in a crisis, it feels like it's taking hours. And it turned out it took 7 minutes for the ambulance to come. It felt like 7 years. And again, she was unable to breathe. And while she was unable to breathe, we were unable to breathe. And the EMTs came in. They didn't know what was wrong in the middle of this crisis, but they were able to give her oxygen to help her breathe. And as soon as we saw them come in to help us, as soon as help came in the door, we began to breathe. As soon as she was able to breathe a little and she was stabilized, we had hope. It turned out my mother had a heart attack and she did survive it. But in that moment, I really understood, as I was processing it, the value of good crisis intervention. It isn't to really know everything that's wrong or how you got here, but rather to stabilize the situation and give everyone enough oxygen to have hope so that they can then move forward and diagnose what the problem is and come up with the plan that's most effective to treat the issue. So without oxygen, you can't build hope. If everything remains unstable, you can't just plan on that system that's unstable. The first thing you have to do is redefine the problem so that you have hope for the future, so that you have a plan. And that comes from building a common understanding between each other, with the person that we're trying to help, with their family, and overcoming disparities so that people feel included, and not just in the room, but participating actively in their own care, in their own support, and that they feel competent. And we overcome those barriers. And that does come from strength spotting. And I showed you that perma chart. We'll be talking more about it. The ability to spot strengths in each other and ourselves is a really key ingredient to be able to have a positive dialogue. And we must have standards of care and practice that are best practice, that are continuously measured, and that allow for us to change when we get evidence that it's not working. So there are lots of times that people try more and more medications or more interventions that are similar without acknowledging that maybe what the problem is that the problem definition was incorrect, and really you need to take a step back and really look at the standards of care and practice and whether or not they meet the needs of the individual. And we have lots of learning communities in order to do that. One of our proudest achievements is our medical directors group. In the beginning, there were like just a couple or 3 or 4 that met regularly, and it has now become a real community of practice nationally, where prescribers and medical directors from START programs from around the United States are able to collaborate and build their practice and improve their practices. And we're very proud of them and the work that they've done to really embrace the idea that all of us, whether we're psychiatrists, direct support professionals, family members, people with lived experiences, we can all learn from each other and build. And part of that is our investment in our community. So all of you who are here today are all part of START. Whether you're here to learn about the model, whether you're here because you're about to learn about what you're expected to do as providers of the model, or whether you're here as partners making referrals to programs that are about to start, we're all part of START. START's success in your local community, in your state, in the country, is the success of all of us. It's all of our success. And so I welcome you to this dialogue, and I hope that this overview was helpful to you. And I have a few more minutes to, I think that was we'll talk about, do you want me to go to tomorrow's agenda, or is there any more discussion? Do people have more to say, Beth?
Did I see Bruce Davis raise his hand?
Go ahead, Bruce Davis.
Hey, how you doing?
Good, how are you doing?
Very well, very well. That was great. Really appreciate you doing all this. And I do want to make clear that we are having START come back to Tennessee. The Developmental Disabilities Council in Tennessee graciously granted us some funding to be able to bring START in to train our assessment and stabilization teams that we're going to have ramped up hopefully by the beginning of January or January of 2021. So we're moving fast in that direction. So I just wanted to make sure that that point was made very clear.
Thank you, Bruce. So Bruce, you stay on there, Bruce. We'll have a little chat. So 10 START in our history was the second implementation of the START model. And Bruce was the director, were you not, Dr. Davis?
I was, yes, I was the director. I was the person in sort of like in charge, I suppose.
Yeah, well, he was surrounded by very powerful women, so
Yes.
he was sort of in charge, right, Bruce?
Right. That's what I meant by that. Yes. Absolutely.
So Karen Weigley, Alice Benson, Bruce Davis, and I were part of 10 Start. 10 Start was highly successful, and actually the publications on 10 Start influenced the development of North Carolina Start. But 4 years into the Start pilot, it was not renewed because 10 Care, which is was their insurance company, had major issues, and there was really no funding available. So 10 Start ended. What year was that, Karen?
Uh,
Bruce, do you know?
Yeah, I think it was 2008 or 2009. It was really mostly because contracts were being cut pretty indiscriminately at that time because of the financial crisis that
Right.
occurred in
So,
'08.
so
So
2009, which is 11 years ago, Bruce and members of their DD council, Wanda especially, persisted on staying engaged with me and START, and also on talking about the return of START. Now, the original 10 START was in Chattanooga, Tennessee. The new 10 START will be statewide. So I think that's a testimonial both to the model, but also to people really buying into the idea that you can have hope for the future, you can make a change, you can keep things going despite obstacles that you face. And so thank you, Bruce. We all thank you. Karen.
yeah, I know. We appreciate y'all, and we're looking forward to this collaboration going forward. I think it's going to be a wonderful
Bruce,
thing here, Tennessee.
This is Karen, Bruce, and just thank you so much for your persistence. It's amazing. We're so excited.
So our California friends thought, oh my God, this whole discussion is going to, of course, be about California. But no, Tennessee has about a third of the participants here today, which is really exciting. So we are very proud of Tennessee. We're also very proud of California and all of our new partners. I can't tell you enough how much we appreciate this opportunity. You have to remember that the original START program had 4 coordinators, a team leader. I was the director. Robert Sovner was the medical director, and we had a clinical director named Paul Zeisel. And I never in my wildest dreams would I be training 500 people on the START model in one day. So it has been quite the journey, and now you're on this road with us. And I really look forward to everything I'm going to learn from all of you. Special shout out to Sklark. If anybody is there from Sklark from yesterday, I loved that meeting. I think you inspire me, and I just want to thank you. Exodus and the Sklark Regional Center, special shout out to you. It was great to meet with you. And to all of you, I'm just very encouraged by having you here and about the work that we're about to do. And for those of you who think that this is like Pollyanna nonsense, we are not Pollyanna. We take positive approaches and strength-based approaches and collaboration seriously, but we also know that what's most important is to have remedies that help people right away. And we'll be talking about that in the next few days. And also having approaches that embrace everyone's ideas and all treatment approaches and all strategies that work for them. So we look forward to our dialogue going forward. And unless there's any other comments, Beth, we're going to close a few minutes early.
There were actually a couple more questions.
Okay, go ahead.
Can you provide an example of START services being provided in addition to a possible behavior intervention service, which is typically pretty intensive to foster all providers being on the same page for continuity?
So, yes. So, a lot of the people that we support are on positive behavioral support plans or behavioral plans. We do not develop those plans. We do not think it's appropriate to duplicate those services. So the way START would partner with those folks, and having a behavior plan to develop skills and strategies to communicate and express yourself is not contradictory to developing a positive identity and ways to flow. And so often the behavior analyst and the START coordinator have a dialogue about how to integrate those approaches to make a lot of sense in supporting children and adults who have behavioral support plans. The other thing we do is START teams have people called coaches who go out into the field to support individuals in who support START enrolled people. So for example, if a child has a behavioral support plan in the family home and the parent is using the plan, the START coach and coordinator might partner with the behavior analyst so that they can help with the coaching and evaluation of the effectiveness of the plan. Do we try to make sure that the plans are not punitive? Yes. Do we try to encourage all plans to promote well-being and positive outcomes? Yes. Do we support restrictive plans that use punishment or any kind of negative reinforcement? No. However, but that being said, we work in partnership with behavior analysts. We also work in partnership with psychiatrists and prescribers. We don't prescribe medication, but we do a lot of support around symptom monitoring, looking at the effects of the medication, making sure everybody understands why they're taking the medication, and the like.
Thank you,
Does that
Joni.
answer that person's question?
Yes. Yes. One more? Time for one more?
Yes.
How does focusing on individual strengths work with systems of care that are deficit driven?
We focus on everyone's strengths. It's cool. So the first thing we do is we acknowledge in the system of care that's deficit driven what they bring to the table that's positive. And we start by fostering a positive dialogue about what we have to offer. We also take what we hear when it's a little bit deficit driven and we reframe it so that it doesn't ignore the deficit, but it also puts it in the context that we described earlier. And then we talk about what the person looks like when they're doing well, because everybody, you know, one of the things you have to remember, even in a deficit-driven system, which is the old medical model, it's no one's fault. In healthcare now, we used to believe that what you did was you diagnosed and treated an illness, and your job was done. So the best thing to do is know what's wrong and then treat it and cure it. It's a cause and cure approach. What we know now in all healthcare is that the health context is as important as the treatment of the illness in order to prevent the person from repeatedly becoming ill. So we just try to put it in that context. We try to address what's going on, but also remind people that if we just focus on addressing what's going wrong, we will never promote the strong, and therefore going wrong will be what we'll be doing, reactive versus proactive strategies. But it takes modeling. And so let me just say one other thing. You can't be an arrogant person. I was going to say but this is a public meeting. You can't be an arrogant person. You can't come in with a condescending attitude, putting people down for where they reside. You have to engage everybody where they are and try to get a perspective on what it means to them, and then try to share your perspective through a respectful dialogue and modeling. And the final thing I'd say is, because we're there for them, the most important thing would start is being true to your word. If there's a crisis and we say we're going to show up, we better well show up. If there's a problem and we say we'll be there to help address it, we better help to address it. If there's if we need to share information, we need to follow up and share it. So our accountability to the system we work with allows us to lead the way to possibly including other ways of thinking that hadn't previously been used by the system. Does that answer that question?
I think it did, Joni. Thank you. Okay.
So these are, it's a real opportunity for me to talk to all of you in this way, because I've been doing this for so long, and doing this work has really enriched my life in ways that I can't even begin to tell you. I just want to let you all know that this work that you're about to engage in is probably going to be the most challenging work that you'll ever do. It's not easy to meet all those standards that we just talked about, really be true to that mission, but it is the most rewarding work you'll ever have. And I mean, Bruce is a testimonial to that. He worked with us a long time ago, and yet this stuck with him, and he's now a very senior official in the state of Tennessee, yet he's embraced this model and this way of thinking in all of his practices. And of course, he had an influence on us as well, and it just stuck with him. And I think you'll find it sticks with you too. Just like Maureen and Donald stuck with me and Bob, there's something very rewarding about helping people in a way that allows them to have ordinary lives. It's really rewarding. So I thank you all for coming today. I look forward to tomorrow. And I just want to welcome you all to the START Network and the START community. And thank you all. And thank you to our tech team. Special shout out to Beth and Anne Marie. Thank you all for being patient with us. And of course, we all love Dan. And we'll see you tomorrow.
Thank you, Joni. This is Beth. I just want to give you a couple closing remarks before we close for the day. Number one, handouts are posted on the website, and we will put a reminder in the chat right now. It is the same Zoom link all 3 days. So when you come back tomorrow at 1 p.m. Eastern, 10 a.m. Pacific, you're going to use the same link that you used today to join, and we'll see you then.